Dr. Sunil Thalve is a professor, head of the Department of Cardiology, former assistant professor in cardiology at the Research Center for nearly 6 years, former in charge of professor in cardiology at various centers, even in Karamsad Medical College also. Huge reoperative skills, and he doesn't need any introduction amongst the cardiologists or even physicians also. He is very popular, soft spoken, and very clear about his ideas. So I would like to request Dr. Sunil Thanvi to kindly go ahead and give his excellent talk. Another is Dr. V.S. Prakash. He is from Bengaluru. He has done his MBBS, MD Medicine Cardiology, MD Medicine from BMC Bangalore. And he has so many research papers under his belt. He is heart specialist and interventional cardiologist at Bangalore. Currently works as an MSR Ramnath Narayan Hospital as a coronary interventionalist, and patients with heart rhythm disorder. He has been expertise in this. Heart failure patients, including biventricular failure. He has received so many awards. I would like to go to the third speaker, is Dr. Jay Shah. Dr. Jay Shah doesn't again need introduction because he's very popular. I know him since years together, and he is a very good, wonderful interventional cardiologist, DNB, DM. He is practicing at Mithakali, and founder, member, and vice president of Krish Heart Institute. He's a teacher in DMB cardiology students in HCG, attachment at Star Hospital and Life Care Institute. He has so many fellowships, national, international, and he is principal investigator in so many studies. He's a co-investigator again in multiple studies. He's a coordinator in CREATE study. Apart from that, he is a wonderful singer. I remember him like that.
Thank you, sir.
I would like to request Dr. Sunil Thanvi to go ahead and deliver a lecture. If he is not available, in that case, Dr. Jay Shah, please.
So thank you very much, all the dignitaries, Dr. Jayesh Trivedi sir. And first of all, I would like to congratulate Dr. Kamal Sharma for a unique platform of having a debate on a particular clinical scenario. And the role which has been given to me is a 77-year-old male, 60 kg of weight with a history of paroxysmal atrial fibrillation, without having a past history of any embolic phenomenon, but having a Chadwick score of 4, HASBLEED score of 2, had underwent angioplasty of right coronary artery for acute inferior MI with 95% proximal lesion almost 2 years back, that is, to be very precise, 22 months back. Apart from the standard care of therapy, the optimum anticoagulation strategy would include, and in this case scenario, I would like to stress upon the scoring system. To be very frank, when we are talking about a very elderly population, like more than 75 years of age, we need to be a little more vigilant regarding the overall scoring system, because the whole area or the whole treatment strategy would depend on that particular thing. So here, if you look at the Chadwick score, which has been given 4, but if you look at the overall scoring system, the history which has been given to us, you can make out that the score would have been 3. So either the patient is having diabetes or hypertension along with the underlying history. And if the patient is having hypertension, then definitely the HASBLEED score cannot be 2. It will directly going into the HASBLEED score of 3. So this is possible only if you have a coexisting hypertension, whereby HASBLEED automatically becomes 3, which is suggestive of high bleeding risk in an advanced age population with a stable coronary artery disease, where angioplasty was being already been done around 22 months back, and patient is having an episode of atrial fibrillation, even though it is a paroxysmal in nature, because we all know that elderly population, the overall prevalence and the incidence of development of atrial fibrillation as the age progresses from 2.8% in more than 65 years of age to 6% in more than 75 years of age to almost 10% in more than 80 years of age. So here I would like to give a due importance in this particular case scenario to 1, advanced stage; 2, the possibility of development of futuristic incipient incidences of atrial fibrillation with special emphasis on the HASBLEED score of 3. And that would be, I would be more concerned regarding the prevention of stroke in an elderly population because of the risk of development of atrial fibrillation or in recurrence of atrial fibrillation. Because we all know that angioplasty has already been done. It has already been past 1 year of an ACS event. So the patient is now in a stable condition. And the trade-off between bleeding and the ischemic events is such that there is a temporal component to the balance of bleeding and the ischemic risk. So how can we titrate the patient to have a high ischemic risk and low bleeding risk, or high bleeding risk and low ischemic risk? In our patient case scenario, I would say that after doing an angioplasty, after 22 months on eventful, the procedure, and the patient is elderly, I would say that this patient is at low ischemic risk, but has high bleeding risk, because even though the HASBLEED score is 4, where the chances of stroke development may be high, but at the same time, HASBLEED is 3, where the bleeding risk, which is a cumulative one, and it is higher with the long term, and a patient who is receiving a potent anticoagulative therapy, definitely the chances of bleeding would be there, and you need to be very, very vigilant in preventing any sort of bleeding from for that particular patient. Now, I'm going to give you certain important points why I'm saying so, and why I'm choosing apixaban, which is available in 5 mg and 2.5 mg twice daily doses in elderly population. Now, which are the risk factors here? High stroke risk because of the Chadwick's 4, high bleeding risk because of the HASBLEED 3, presence of CAD with a past history of PCI. So patient is in a stable CAD, or you can say that after a COMPASS trial for rivaroxaban, patient is in a CCS condition. But elderly population, you need to just be very sure about the overall risk and the benefit ratio as compared to the ischemic and the bleeding risk ratio. Whenever we are talking about an elderly population, and here we are talking about advanced age, that means the age more than 75. Multimorbidity, the history of, or rather the possibility of development of risk of fall, risk of GI bleed, polypharmacy, vascular dementia, frailty, all these things are taken into consideration when we prescribe any sort of oral anticoagulation therapy in an elderly population. And one thing is very clear, whether it is Aristotle or any other trial like Relay or Rocket AF, all this trial of all these Noacs, they have proven one thing, that factor Xa inhibitor, they are definitely superior than warfarin. So vitamin K antagonist is definitely out of question when we are talking about non-valvular AF, whether it is safety or whether it is efficacy. So in that case, when we are talking about summary of major efficacy and the safety outcome, even though we know that there is no possibility of head-to-head comparison, it does not exist between rivaroxaban and apixaban, even though there are fewer recent articles which are being published between rivaroxaban and apixaban, which we are going to see in subsequent slides. Apixaban is, as of now, probably the most safest molecule available as far as the oral anticoagulant drugs are concerned, whether it is stroke and systemic illness where efficacy is concerned, or there is a presence of major bleed or ICH, or for that matter, even an all-cause mortality, which is better as compared to warfarin, and which has been proven with apixaban. And if you look at the Aristotle trial, you can see that the net clinical events rates are low with apixaban as compared to placebo, where the standard care of therapy is concerned. Whether the stroke or the ischemic embolization, all-cause mortality, major or all-cause bleeding or intracranial bleeding is concerned, as the age advances, the benefit increases. In elderly population, I think apixaban has definitely proven its efficacy as well as safety. Now, coming back to the data where all this comparison is being done between Riva, Debi, and apixaban, the data of major 4 trials, they've shown that in an elderly population, the efficacy is same as that of dabigatran, or for that matter, even in elderly population, it is same as that of even rivaroxaban. But what about the safety? Safety, here you can see that in more than 75 of age, rivaroxaban is inferior, or it is not producing a better benefits as compared to apixaban. And apixaban, more than 75 of age, definitely it is going to give you a better result, irrespective of the age criteria. The safety profile or for major bleeding is definitely better with apixaban as compared to dabigatran. Dabigatran, we all know that it is very efficacious as far as the stroke prevention is concerned in 150 milligram dose. But what about the safety? In elderly population, more than 75 of age, dabigatran produces more bleeding, which is statistically significant. So that is the reason meta-analysis of multiple randomized control trial have proven that in an elderly population, which Noac is better as far as the comparison is concerned. I think apixaban scores over rest of the Noacs. And now coming back to some of the real world evidences in elderly population, we all know that Aristophan is the trial which has shown data about elderly population having better benefits with apixaban as compared to warfarin, whether it is stroke or systemic illness or major bleeding is concerned. Apixaban and other Noacs, they are being managed or maintained irrespective of the doses, where you are using reduced dose, either with dabigatran, rivaroxaban or apixaban. Even with the reduced dose of apixaban and of dabigatran, they are associated with lower risk of major bleeding as compared to a reduced dose of rivaroxaban. And with that, if you look at the meta-analysis in a patient with all this category with more than 75 years of age and having an episode of atrial fibrillation, apixaban offers to be a better combination as far as the efficacy and the safety data are concerned. There's a very important or a statement which has been given as an international consensus validation of FOTA label. FOTA means fit for the aged classification, where this class was being given an A class, which is an indispensable, and that has been given to apixaban. And that is the reason more than 75 years of age, all the experts, they are saying that apixaban 5 mg twice daily should be the first choice, followed by second choice of rivaroxaban 20 mg or dabigatran 110 mg twice daily. Here we all know that the patient is at high risk of stroke because the Chadwick score of 4, but at the same time, patient is having a HASBLEED score of 3, which makes him at a high risk of bleeding as well. So irrespective of a Chadwick's score or a HASBLEED score, there's a data which is shown by Dr. Lopez that apixaban had less net clinical events with lower chances of development of stroke, systemic embolization or major bleeding. Irrespective of this scoring system, apixaban has reduction in the major bleeding and in the intracranial bleeding as well. Now, when we are comparing rivaroxaban versus apixaban with underlying major ischemic or hemorrhagic event in patient with atrial fibrillation, you can see that even with a reduced dose of apixaban, it is going to give you the best benefit possibility as compared to rivaroxaban, whether it is ischemic or hemorrhagic complication. And whenever we are using standard dose, then also apixaban scores over rivaroxaban in this particular study design. Another important point which was being studied very recently in December 2021, which was being published in JAMA, and that was being done by Todd Mean, and it has shown that the data for apixaban as far as the safety is concerned, they are superseding, or rather they are having a much better benefits as compared to rest of the molecule, and especially rivaroxaban. Effect of apixaban versus warfarin as far as the safety is concerned, I think in CAD cases, definitely apixaban scores over rest of the vitamin K antagonist or molecule. And in nutshell, if I wanted to say that apixaban had 55% and 60% lower risk of association of GI bleed, which is more common with dabigatran and with rivaroxaban. Yes, sir. Yes, sir. It will take hardly 1 minute now. In the very elderly population, and that is the reason I think apixaban scores over rest of the molecule. And as we know that elderly population, they are developing or they are at more risk of development of altered EGFR, where even there is no dose adjustment is required as per the underlying EGFR. And that is, these are some of the benefits which we are seeing with apixaban. So with that, I would like to end my talk, and I would say that one thing is very clear, that how can you titrate the therapy? How can we stratify the risk for the underlying patient? Here we are talking about a patient who is 77 years of age, elderly population with HASBLEED score of 3 and an increased chances of development of atrial fibrillation. The dose which is not requiring a multiple titration and the dose which has already been proven is apixaban as compared to rivaroxaban. Whenever we are using rivaroxaban in such type of scenario, then rivaroxaban in which dose to be used, that is also an area of debate, which I am going to give after the talk of rivaroxaban and dabigatran respectively. Thank you so much.
Dr. Jai, we would like to request Dr. V.S. Prakash sir to please go ahead with his presentation. We'll take discussion afterwards.
Yeah. Thank you. Thanks for this kind invite. I thank Dr. Kamal Sharma for having me on this wonderful conference. And I think I would share my slides. Yeah, just a second. With due respect to my previous speaker, I think he did a wonderful job really establishing the importance of apixaban in this kind of situation. I will not go into the case scenario because he did elaborate on that, but I'll just make a little deviation. His emphasis was on the elderly and the risk of bleeding. Let us see whether we have any other way of looking at this patient. I would kind of mention that what is more important here is my disclaimer. And yes, he did emphasize on, see, one important thing here is the CHA2DS4. Another important thing was diabetes. And we have underlying coronary artery disease, PCI, and an elderly, right? We understand that. Now, let us look at the RCTs, which are our major support for Noac versus warfarin. If you look at this patient, elderly with a CHA2DS4 and a diabetic, which RCT represented this person very well? It was the Rocket AF. Rocket AF had 40% of patients being diabetics, and the CHA2DS score was 3.7. So we understand that now we have evidence with regard to rivaroxaban in this subset of patients. Diabetic patients, see, why are we worried? Diabetic patients who have AFib have higher risk of death and cardiovascular events as compared to those without AFib. 61% increase in the relative risk with deaths and cerebrovascular events. We have not spoken about that at all. What does the Rocket AF tell about this? Very clearly, if you understand, rivaroxaban significantly reduced cardiovascular death by 20% in this subset of patients, diabetic patients. What about apixaban? See, the problem, apixaban versus diabetic versus non-diabetics, the risk of bleeding was more with apixaban, 3% per year versus 1.9%. So very clearly, ESC gave a warning. ESC 2020 said bleeding risk with Noac is similar in diabetics and non-diabetics, except for apixaban. So they put a marker, red herring there. Now, why are we talking so much about diabetes? See, we know diabetes has injurious effects, macrovascular complications, coronary artery disease, peripheral vascular disease, stroke. Not only that, microvascular complications, nephropathy, neuropathy, retinopathy. What is that got to do with our particular molecule, rivaroxaban? We have a large real-world data, the RIVA-DM. More than 1 lakh patients were evaluated in this real-world data, where they not only looked at the safety, efficacy, as also the risk of bleeding. They also looked at renal outcomes, limb outcomes, ophthalmic outcomes. That is the evidence we have with rivaroxaban. Here, very clearly versus warfarin, it scored in all these aspects, not only efficacy and safety, also in reduction or worsening of renal function, of major adverse limb events, and diabetic retinopathy. Hazard ratio, if you see, has always been on the lower side compared to warfarin. So we understand emerging data such as that rivaroxaban may help not only to reduce stroke, but also diabetic complications in patients with AFib throughout the body, all the micro and macrovascular complications. Let's look at now underlying coronary artery disease. What do we have here? We know this patient has undergone PCI 22 months back, so he is a stable coronary artery disease. And what does that mean according to the ESC 2020 guidelines? All that you need to do is use a single agent and Noac. You don't need dual antiplatelets or even a combination therapy. Do we have evidence for that? Yes, in the form of the Artery trial, which was conducted in Japan. And here again, these patients had undergone PCI or CABG more than a year prior to the trial. And here very clearly, rivaroxaban standalone versus a combination therapy clearly stood out with regard to reduction in the major bleeding, and also efficacy-wise, it stood up with a hazard ratio of 0.72, again establishing we have real-world evidence working for rivaroxaban. Age. Age is a very important factor. My respected opponent did mention, what evidence do we have with regard to age? Again, Rocket AF had the maximum number of patients beyond 75 years of age, 44%, versus apixaban was only 31%. And so what does this show? If you look at the elderly people more than 75 years of age, if you're looking at all-cause mortality, if you're looking at non-hemorrhagic strokes and life risk of bleeding, all this, again, patients in the elderly more than 75, rivaroxaban did better compared to the younger, clearly showing that rivaroxaban is safe in the elderly and probably performing better compared to the young. So back to our case, in such a scenario, rivaroxaban is the most evidence-based Noac because we have enough data. And not only that, also widely used and having consistent results. So my backing would be for rivaroxaban in this particular scenario, patient being diabetic, having multiple complications, undergone PCI, we have maximum evidence with rivaroxaban. Thank you.
So can I make one point, sir?
No, we will take it afterwards.
Okay, fine.
Thank you so much, sir.
Thank
Kindly be with us because we will have a discussion afterwards.
Sure,
I would like to
thank you.
request Dr. Sunil Thanvi to please present his case.
Yeah, thank you, Dr. JHB. Yeah, hi, Kamal. Congrats for a very nice conference. I think it's a very nice concept, this Bout thing. I'm here for the first time, but I'm really impressed by the way things are going. And I think it's a very apt topic to discuss about because we have so many Noacs now. This particular scenario that has been given to us is a very day-to-day sort of a situation wherein we face such patients and we need to take a call as to what would be the best option in these patients. So I'll be pitching in for dabigatran today. I've heard Dr. Prakash and Dr. Jay, and I'll be putting my thing forward for dabigatran. Next slide. I think when we talk about dabigatran, it's one of the most widely studied Noac till date. We have been using it for donkey years now. And I think in various scenarios, it has been studied and it has always come out trumps whatever data has been there for this particular molecule. Next, I'm not going into the case details because I think they've been discussed very well. But the point is, he's an elderly male, has undergone an angioplasty about a couple of years back, and he is at high risk of stroke with a moderate risk of bleeding. Now, if you look at the read-all PCI that was there, you can see most of the patients, maybe nearly 77% of patients, which were less than 70 years of age in Japan, but less than 80 years of age in USA and rest of the world, were on dabigatran 110. And while dabigatran 150, 99% of patients were there. If you look at diabetic status, again, they were in the range of 37, 38 to 40%. So it was quite a decent number of patients in diabetes too. And of course, the CAT score mean was roughly around 3.7 to 3.8, which again goes with this particular case. And the modified HASBLEED score was around less than 3. So I think this is an apt indication what we're talking about. Mason indicator PCI was there in about 52% of patients, and DES was placed in about 84%, which is a normal practice that we do in today's world. Next. So 3 points next. So there are 3 points I need to highlight as far as this case is concerned. Next. Now, when you look at the various pointers that are there, we are looking at age now. And if you look at, either major or clinically relevant non-major bleeding, if it is a patient less than 75 years or more than 75 years, we can see that the data as compared to warfarin is almost the same. If you're looking at death or thromboembolic phenomena or inflammatory vascularization, definitely less than 75 years, it favors dabigatran. More than 75, there's some data for benefit towards warfarin, but it's still a very gray zone. Next. Next, we are looking at renal impairment, which is not, next slide. Yeah. Renal impairment, again, as we see that at a create clearance, which is a 32 less than 50, which may be quite common in these elderly patients, especially if it's a diabetic. Nobody has talked about this. And even if the create clearance is, less than 50, and there is a 32 less than 50, still dabigatran would be the drug of choice that we might use as compared to rivaroxaban or even apixaban for that matter. Next slide. Acute coronary, next slide. So in acute coronary, again, if you look at major or non-major bleeding, in ACS or non-ACS, dabigatran 150 definitely has a better outcome as compared to warfarin, while even for death or thrombotic phenomena or unplanned revascularization, dabigatran again is superior as compared to warfarin alone. Next, to look at the PCI complexity, whatever the complexity that the patient is in, the data is very clear that even with a low dose of dabigatran dual therapy, or whether it's a high dose dabigatran 150 milligram twice a day dual therapy, still is much better than warfarin triple therapy as compared to, in various complex situations, whether it's clinical complexity or whether it's procedural complexity. In other case, dabigatran has found to be much more beneficial as compared to warfarin alone. Next. Next slide. Yeah. So this shows the time to first event in days. Dabigatran 50 milligram dual therapy, dabigatran 110 milligram dual therapy, and warfarin triple therapy. You can see that the event rates are much less as with dabigatran as compared to warfarin triple therapy patients. Next. Next slide. Yeah. So overall, if you look at redual PCI, there was significant reduction of major bleeding events without compromising ischemic events, and the patient profile typically, as we see in this, is high risk of stroke, high risk of bleeding, elderly, BMI, even if it is on the higher side, will still help. ACS, Pci complexity, whatever stent type, renal impairment, diabetic patients, definitely dabigatran still has an upper hand. And other consideration, choice of P2 inhibitor, whatever it is, previously on VKS, still we can give. Time in therapeutic range, whatever it was, and of course, presence of proton pump inhibitors. Still, this shows that dual antithropic therapy with dabigatran is still superior as compared to triple therapy with warfarin. Next slide. If patient develops risk of increased bleeding in the future, needing reduced dose of Noac, what to do? The patient has a GI bleed, but still requires an anticoagulation. Next slide. Can we go down on the dose of any other Noac? If you look at the recommendations, if you look at the data, this is from the European Heart Association, Rhythm Association, 2021, which clearly says Noac at standard dose, there are only two things that they can give. One is dabigatran 110 milligram twice a day, and of course, apixaban 5 milligram twice a day. Rivaroxaban reduced dose is not really indicated when you need to cut down on the doses. Consider dabigatran 110 milligram twice a day. Other dose reductions are off-label and not studied in unselected patients. Reassess alternative strategy for stroke prevention. Maybe we can think about a left appendage occlusion, but we cannot really consider going down on dose of other Noacs. So this is again where dabigatran helps you, where you feel that the dose needs to be reduced for clinical event rates. Probably this is one molecule where we may not hesitate from going down to from 150 to 110 and still give the benefit that the patient should be getting. Next slide. So this is a slide which says that even at 110 milligram, as compared to warfarin, the event rates are much, much less, and therefore the patients will still benefit if the patient has a lower dose. But with other Noacs, this is not the case. So I think this is again one area where dabigatran definitely helps us in continuing the molecule, but at a reduced dose and still giving the benefits. Next. Danish history of comparison of low dose of Noacs very clearly showed us that apixaban 2.5 milligram twice a day demonstrated a trend towards higher rates of ischemic stroke or systemic embolism versus warfarin. Next. Reduced dose of apixaban and rivaroxaban showed increased mortality versus warfarin. Next. When talking about any bleeding, in fact, dabigatran 110 twice a day was the only molecule which showed significantly less bleeding events versus warfarin. Next. So I think the data is very clear out there that, in patients like these who are on antiplatelets, who are frail, who are diabetic, elderly, who might be having underlying renal issues, probably giving even a low dose of dabigatran would still be beneficial as compared to other molecules. In Garfield AF, a very classic study which looked at various factor inhibitors versus dabigatran versus VKS and no Noac. So it was almost a similar subgroup we have chosen for this, and the data very clearly said. Next slide. That as compared to VKA, Noac's overall showed significantly lower rate of major bleeding and all-cause mortality, while for non-hemorrhagic stroke or septic embolism, the rates were almost similar. But if you look at dabigatran, major bleeding was less, non-hemorrhagic stroke or septic embolism was almost at par, and all-cause mortality was definitely the least as compared to other molecules. Factor Xa included all the other three molecules. So vis-a-vis other molecules, any Noac, no Noac, VKA, factor inhibitors, Garfield have clearly showed that dabigatran was much superior as compared to other molecules. Next. So are all Noacs the same? We are coming to the end of this debate, and this is a slide which very clearly tells us dabigatran 150, dabigatran 110, rivaroxaban 20 or 15, and apixaban 5 or 2.5. If you look at the dosing frequency, of course, RCT's major bleeding versus warfarin, you can see reduction was 20% with dabigatran, apixaban is 29%. ICH was warfarin, again, huge reductions seen with dabigatran, while not so great with other rivaroxaban or apixaban. Stroke system embolism versus warfarin, again, it is huge with dabigatran 150 milligram, but not so with other molecules. And ischemic stroke versus warfarin, again, dabigatran 150 milligram definitely shows much more superiority as compared to any other molecule. Next. So in a nutshell, superiority of molecule is not at all a concern. I think, dabigatran is one of the best molecules that has been studied in this particular, patient subgroup, and it has given us the best possible safety and efficacy data. Now comes the crunch point. We have talked about reducing the doses. What if the patient bleeds? What if you need a reversal? Is there any reversal agent available for any of these agents? No, it is only dabigatran for which we have a reversal agent widely available, and within 1 hour, even in Ahmedabad, you can get the molecule and reverse the bleeding and get the patient operated, or for whatever reasons you need to reverse it within an immediate span of time. Next. Next.
Sunil, last 1 minute.
Yeah, sure, sir. Just a couple of slides more. An FDA or analysis of more than, 5 lakh patients, standard dose of Noac and warfarin very clearly showed that dabigatran 150 milligram, ICH, thromboembolic stroke, death, definitely very significant. Next. Versus rivaroxaban, again, you can see it is quite significant. Next. Versus apixaban, again, it shows significant reduction for ICH, similar for stroke and death. So I think this for increase for apixaban as compared to dabigatran alone. So next slide. So these are real world evidence now. And of course, the reversal molecule, adagrasib, that is available widely. And whenever it is required to be reversed, we can definitely do that. It's specific targets dabigatran, helps the patient, saves lives. Next. So to conclude, I would say that results from RCTs consistently demonstrate a favorable safety and efficacy profile in both the doses, patients with AF. Real evidence supports the safety and effectiveness of dabigatran, both the doses, providing insights into treatment outcomes in everyday clinical practice and varied settings. Evidence from studies like Garfield AF adds to the evidence of significant benefit and safety with dabigatran in the real world. So I would not hesitate in keeping this patient on a dual antithrombotic therapy with dabigatran, either standard dose or lower dose, depending on the clinical scenario, and give the patient benefit of both PCI as well as the patient being on for stroke prevention. Thank you very much for a patient listening. Thank you again.
Thank you, Sunil. The forum is open for discussion. We'll have a discussion for 10 minutes time. Please go ahead. Yes, Jay, you wanted to tell something.
Yeah, I just wanted to tell one thing, that the history which has been given to us as a part of Bout, it has not mentioned diabetic status. Number one. Number two, so as you have assumed that patient might be having diabetes, because we all know that once the patient is having diabetes, the whole scenario would be changing. Then the chances of more high thrombotic risk will be there. But as Kamal Bhai has specifically mentioned, that patient is 77 years of age, then past history of angioplasty, 22 months back, with Chadwick score of 4. But with Chadwick score of 4, you cannot have a HASBLEED score of 2. It has to be 3. And there, the choice which has been left as per the scoring system is just the hypertension. Now, whenever you have a hypertension, you are more concerned about the development of future stroke because of the underlying atrial fibrillation in a stable coronary artery disease patient where already angioplasty is being done for a single vessel disease 22 months back. And that is my area of debate, that in that scenario, would you like to choose the most safest molecule available, which does not require any dose titration, which does not affect with any dose, drug interaction or food interaction? Likewise, you see it with dabigatran. And as far as the advanced age is concerned, because age itself is an independent risk predictor for high bleeding in such type of scenario. So I think
I always keep this loophole in the scoring, and Jay always picks it up and harps upon it. So I always keep one of the risk factors missing.
Sorry to intrude. I think Dr. Jay, you're missed. He's a diabetic.
No, it's not been mentioned.
Please read.
No, he's diabetic. He's diabetic.
The history which has been given to me.
So my question.
Same thing. If we are talking about the same patient, he's a diabetic. You very clearly mentioned a 77-year-old diabetic patient.
But the history which has been given to me in
then we may be
I think that diabetic, non-diabetics does make a big impact. We understand, and what Dr. Jay is talking about, he's right, because the first debate when it was framed did not mention diabetic, and Dr. Prakash, we added diabetic. We also acknowledge that. So there might be an overlook, but understanding the science that
we're all winners.
So the point is well driven. That if the diabetic or hypertensive, the scenario does change between the science. It's not all Noacs become equal, number one. Number two, I would like to ask all three of you, including Dr. Thanvi, how does this 22-month change if you make it, say, 2 months or 12 months or 6 months in the current guidelines of Noacs? Because if you had a patient you've put a stent and the guidelines do talk about taking it off, then does the table tilt more in favor of dabigatran, Dr. Thanvi, if this was more recent as compared to apixaban? Just for the sake of igniting further discussion.
Yeah, see, I am totally sold up on the idea of the fact that for a dual antithrombotic therapy, I think dabigatran has the best possible data available to date. And I think that is where it scores. Coming to Jay's point, I think I'm sure he missed that the first sentence mentions a diabetic male. Nevertheless, but still, elderly patient, diabetic patients, post-ACS, if you look at whatever indications are there, dabigatran has been studied very extensively, both in randomized trials as well as real-world scenarios. And it has been very clearly shown that at 150 milligram, it is the best molecule to prevent systemic stroke or embolism as compared to any other Noac available. So if you're talking purely about, cutting down on stroke and systemic embolism, I think dabigatran is a drug of choice that should be used. Right now, coming to the age, 77, actually 80 is the cutoff, right? More than 75, 80 is actually the cutoff. This is a 77-year-old male. Again, it's a gray zone where, I would still err in favor of giving a dual antithrombotic therapy with dabigatran, given the fact that even if he bleeds, you might cut down on the dose, you might have a reversal agent on hand, which might help. Of course, we assume that, it may not be needed, but you never know. The patient might need to go again for a repeat procedure, may require, surgery, may land up with an ICH because it's hypertensive. So see, there are certain considerations that are there in my mind. So as far as I'm concerned, I'm still sold on the idea of giving dabigatran. I definitely agree apixaban has good data in elderly patients, but I think the balance is there for both. And I wouldn't hesitate in adding dabigatran as far as I go.
So ultimately, it will be left to the physician's discretion.
I agree. It's a totally individual approach.
It's an individual approach, and
see, honestly, there is no head-to-head comparison.
Yeah, it will never happen, sir. It will never happen.
Yeah. See, the thing is, all comparison with warfarin and which you are trying to. We do understand that each molecule has its own kind of niche indication. We have more data with diabetes with regard to rivaroxaban, and more data with regard to elderly with regard to apixaban. And GI bleeds, definitely, I think dabigatran and apixaban score over rivaroxaban in that issue. But, I think it's a kind of individualistic decision that, as you say, finally, it's patient specific. And then you need to take a call as to which molecule would be the best here.
Yeah.
But one thing is very sure that all these AF patient, we as a fraternity as well as physician, they have to use this scoring system just to make sure that this is why we are choosing this molecule. So the scoring system is really going to be very helpful for deciding the strategy.
So I'll add a caveat to that, Jay, saying that all of us have to use Noacs first.
Yes, correct.
Unquestioned. There's absolutely
that is beyond doubt.
No debate on that.
Yeah, there's no debate on that.
There's still so much of hesitancy regarding using an oral anticoagulant in AF patients. Most of them would be either be on aspirin or clopidogrel for whatever reasons, and ultimately we are not giving the benefit of anticoagulant to this patient. So on this forum, I want to make it very clear: aspirin, clopi doesn't work. It has to be anticoagulation. The molecule will depend on the clinical scenario, patient-specific characteristics, and individual preference. I would add to that because we are all comfortable with a particular group of molecule. So I think
the most important aspect, I agree with you, is the risk of stroke is more worrisome to a patient rather than the risk of bleeding. So obviously, you definitely want to use a drug which is more efficacious with regard to, but at the same time, and we also understand the risk of bleeding is much lower with Noacs versus warfarin. In all the three Noacs. So I don't
think point is well taken that Noacs are going to be the main cornerstone of therapy. So warfarin we need to forget. As Sunil B has told, aspirin and clopidogrel we need to forget the role. And after 1 year, I think it's better that we need to go ahead with the monotherapy. of Noac.
Perfect.
So I think there is a consensus about the anticoagulant therapy, Noac. Thank you so much, sir, all speakers and chairman and co-chairman. Now we will go ahead with the next topic.
Thank you, everyone. Fantastic debate.
Thank you so much.
You would like to add something?
I think Devang Bhai is saying he is more confused at the end of the talk. So can somebody summarize, chairperson?
Devang said that
I think when you have a lot of debaters who end up with putting their points, so Devang Bhai is saying he is more confused. So chairpersons, Gaurav, Sanjay, Keval, you want to summarize?
They left long back.
So I think what the conclusion I am trying to draw is that if you're dealing with an acute C event where you need to be choosing DAPT in the acute setting, probably dabigatran is weighing heavily. Diabetics, you have more data for rivaroxaban. Renal failure, you have more data for rivaroxaban. Apixaban is definitely safest, no doubt about it. If you're looking at somebody who's got high HASBLEED, and you have to position it probably that. This case scenario has mixture of all three, and that's why we actually created this debate. Dr. Devang Bhai, I hope I'm clear. Yeah, so now he says that he is very clear. Thank you very much. Thank you. We move to next session. Bye-bye. Thank you.
Devang has clarified himself. He is clear now. Thank you, Devang. Now we will go to the next topic. Thank you so much to all my speakers and chairman.
Thank you.